Moving on, let's talk about our supraglottic airways. Supraglottic airways have come a great distance in the last couple of decades and have become really great rescue tools, and some might even argue primary tools for some of the patients. So let's talk about the tips and the pearls to using supraglottic airways. They do have some limitations. Patients with airway swelling, patients with an active obstruction, and patients with high airway pressures may be patients that a supraglottic won't be ideal for. Now, this is not to say if I'm a failed airway algorithm that I can't grab for this tool. Absolutely do grab for these tools in a failed algorithm. But remember, as you're risk stratifying a patient, these are some of the limitations for this device. The iGel is by far and away the most popular in our region. This is a second generation supraglottic. All that means is it gives you a gastric tube so that when you insert the device, you can actually put a gastric tube down that gastric channel and you can decompress the stomach. So if someone has been bagging a patient for a long time before you put the supraglottic in, or if the patient has some active emesis come up the tube, pull the device, suction the airway, but when you replace the device, get that suction tube down. Keep in mind, most manufacturers don't have the right size OG tube for the device you have. So as you're doing your rig checks, take a look at your iGels and what size OG tubes each of them need, and see if you have them on hand, because in a pinch, you don't want to have to be searching for these. Now, these devices by the manufacturer's guideline are weight-based. There's an OR study that said, actually, we can just do gender-based. And let's face it, that's a lot easier than guessing their weight. So most women are a size 4 iGel. Most men are a size 5. And arguably, most of our mannequins, a size 3 works just great. But we're not intubating mannequins out in the real world. So a quick tool is just quick gender-based. A 4 or a 5 will work for most adults. If I'm using these on children, I'm using my length-based resuscitation tape or app or cards. Rapid sequence airway we talked about a little bit earlier, but this is something that you might keep an eye out for. If I have a patient who's in a confined space or maybe trapped in a car and they're still awake enough that I can't just put an iGel in them, maybe they have a gag reflex, but they're not controlling their airway, and I don't want to intubate them in some awkward position and fail. Rapid sequence airway may be a great alternative. So in this case, I give the medications to sedate the patient and maybe even paralyze them. And then I put in the supraglottic. It's quick, it's easy. I'll help control the airway until we can get them out of this confined space. And once they're out and safe in your rig, you can choose if it's time to intubate them if you need to or not. Now, there's not a lot of evidence on this, but it's starting to grow. We'll talk about it a little bit more when we talk about trauma patients. So, troubleshooting the supraglottic. So, once you have this device placed, your sort of first confirmation is you squeeze the bag and you have chest rise. Generally, that tells you it's in the right place. But we're also going to want to get end tidal CO2, just like we do with ET tubes, make sure the patient is oxygenating, and the general sort of look of the patient should be improving. Now, as you're troubleshooting, you may have a patient when you can ventilate them, you have chest rise, you have end tidal, but the SATs just aren't coming up. If this is the case, you have to ask yourself, is the problem intrinsic to the patient or is it intrinsic to the device? Things that are intrinsic to the patient are things like attention pneumo. An iGel won't fix that. That person needs a needle decompression, mucus plugging, or bronchospasm. So remember, our patients who have asthma or COPD may have high airway pressures, and the iGel doesn't have a strong enough seal to ventilate these patients. Sometimes mucus plugging or bronchospasm causing high pressures may require intubation. And then lastly, think about your device. So is the device obstructed? Was there mucus in the airway? Is there emesis? Is there food? You need to pull this device out, go in with your suction, take a look, and then you can reinsert it. And then sometimes it's as simple as the epiglottis just flops down over the outlet of the SGA. So this is called herniation of the epiglottis. The simple fix for this is slide the device out and then slide it back in. So not fully out, but kind of a half lift and reinsert it till it seats and then try to bag again. Usually this will overcome this, and the epiglottis will flop right over that epiglottic rest that you see on your eye gel. So let's look at some evidence, and we're talking about supraglottics versus ET tubes. There's been big talks of this in the last 8 years or so. So two trials that came out, one in 2018 and one in 2019. These two trials were like 15,000 pre-hospital patients. The PART trial was looking at the King Airway, and the Airways 2 trial was looking at the iGel. And what both of these out-of-hospital cardiac arrest trials found was there was no difference between intubating patients in the field or using supraglottic devices. They didn't have higher rates of aspiration or complications, and the survival with neurologic outcome was the same. So the evidence in the last few years has just been telling us the same story. So in 2024, they published a study that said actually doesn't matter about any type of oxygenation that you do in out-of-hospital cardiac arrest. You could just beg the patient if you want. And then also this year, they published a meta-analysis looking at supraglottics versus tracheal intubation. So they looked at a whole bunch of control trials, including PART and Airways 2, I believe, that just kept reinforcing the same take home. In out-of-hospital cardiac arrest, it doesn't matter if you intubate or use a supraglottic device. Focus on the things you know that matter, like high-quality CPR, early defibrillation. Otherwise, it is dealer's choice. Maybe you start with an iGel, perform high-quality CPR, and when you get more resources and all of your cardiac arrest priorities are taken care of, maybe then you switch to a supraglottic device. Or some people may wait till they get ROSC, and arguably, some people are right to just put the iGel gel in and go with it, because if it's not broke, why fix it? So thinking about these two procedures, when I'm thinking about intubating, it's more technical, it requires more positioning, and a lot of these out-of-hospital cardiac arrests show really low first pass success in 50 or 60%. Whereas a supraglottic is easy to use, variable positioning, and it has high first pass success. High fast first pass success in this case is a single insertion of the device to chest rise. And don't forget, many EMTs can do your supraglottic device placement, and that just has the paramedic free to worry about bigger priorities. The bottom line here is use your clinical judgment for the patient in front of you. If you have a patient who has active emesis or bleeding and the iGel is not protecting their airway, that's a patient you may need to intubate.